Hey, good morning, everybody. I'm John Simoes, and it's great to be back with you. Good morning, everybody. It's great to be back with you. I'm John Simoes. Thank you for joining us here today. Protect Our Care is going to host today a conversation to highlight not only a new report that has found growing pressures facing rural hospitals and healthcare access across New Hampshire, but across the whole country. I don't have to tell you that programs like Medicaid and the Affordable Care Act play a critical role in supporting care for thousands of Granite Staters and sustain hospitals and clinics in our rural areas and underserved communities. I also have to remind you that 50% of New Hampshire is considered a rural area. So as costs rise and financial pressures increase, providers are being forced to make very difficult choices that impact services and staffing and access to care. Across our state and the country, we're feeling the strain. There are workforce shortages, skyrocketing costs, increased pressure on rural providers. But without long-term change, communities risk losing even more access to essential services from emergency care to maternity care, forcing patients to travel further and wait longer for treatment. So I'm joined today by someone who has been navigating these headwinds firsthand, Ed Shanshala, who is the CEO of Ammonoosuc Community Health Services, recently had to make a very difficult decision to close a clinic in Franconia in the North Country due to these ongoing financial pressures. His experience hopefully will give us a perspective on what's happening right now on the ground in New Hampshire and where we're heading. Ed, hey, it's good to see you. Let's start by, could you give us an overview of the realities facing providers today, including Medicaid and ACA changes, workforce challenges, and can you tell us where is the pressure most acute right now in New Hampshire?
Mhm. Yeah, thanks, Jaime. For context, we're in northern New Hampshire in the White Mountains, and as a federally qualified health center, one of 1,400 in the country, we're in a rural area. Others are in urban areas as well. We have 26 towns, 30,000 residents. We see roughly one in three. And as Jaime mentioned, until last year, we had five care delivery sites, staffed with 100 um, ACHS staffers and pushing close to 10,000 patients. As time has gone on, and especially with legislation passed last July and the adverse impact on Medicaid and on co-investments in the Affordable Care Act health insurance marketplace, we were forced to close our ACHS Franconia care delivery sites, preemptively anticipating that these cuts would happen, and I think they are happening. We did not have to lay off staff, which is good news. We have patient navigators to help patients uh, find the transportation they need to either come to Littleton or to go to Whitefield. So as Jaime had mentioned, when we look at the broader healthcare environment in the North Country, uh, I have a federally qualified health center to my south at Midstate and Coos to the north. I'm surrounded by several critical access hospitals from Spear in Plymouth, Cottage in Woodsville, Littleton Regional, Weeks, Androscoggin, and Upper Connecticut. And we're all feeling the tension and pressure on changes as a result of this law on Medicaid, on the Affordable Care Act, and on what's called the MET tax, which decreases our ability to bring federal monies into the state, which are invested into our critical access hospitals. So there's a lot of moving targets going on. Access is important for us. John mentioned obstetric care. You can deliver a baby at Spear in Plymouth. You can deliver a baby in Littleton at Littleton Regional and Androscoggin in Berlin. And that is the only critical access hospital in the entirety of Coos County has the capacity to deliver babies. So when we think about the capacity to deliver babies, it gets us to the workforce. And for me to recruit people, regardless of a patient access specialist, a certified coder, physician, nurse practitioner, younger people have questions. Tell me about the schools. Where am I going to deliver my baby? And so with obstetric care at risk, it's not only devastating for a community who may have to drive many more miles to deliver a baby. It makes it much more difficult for us to recruit if I have to say, in an entire county, there is no place to deliver a baby in a hospital setting. That's not something you want to be able to convey. So that's the environment we're in with current situations that are going on in the world. Food costs are going up. Um, Gasoline prices are going up. That adversely affects our patients. It adversely affects our staff. So those are those broader concerns that we didn't anticipate last July. That gas was where it was, food was where it was, and inflation was maybe starting to come under something more reasonable. That's no longer true. So when people ask me how I'm doing, I channel a little Stephen Covey. We're doing exceptional for the things that are inside our control. We hold on really tight to that realm of control. We lean out, we have conversations with policymakers and try to educate them on the value of investing in healthcare in the North Country. And then we kind of keep track of what's going on in the world, but it's not our realm of control. It's not our realm of influence. We try to focus on the patients in our community and be successful there. So that's where we are today in April.
Well, thank you, Ed. And I want to follow up with something which unfortunately we both know we saw with the last round of open enrollment. We lost people signed up for the Affordable Care Act, a few thousand. And we know that Medicaid has also lost people as well. So at the same time, we're seeing hospital costs really rising, not just across New Hampshire, but across the country. And with that, insurance costs are going up. So this is a combination of funding pressures and uncompensated care, which I'm assuming are ultimately going to show up in our premiums and our out-of-pocket costs. But could you talk about what's the impact on families, but also on rural care providers? It seems like both sides are getting hit with these things.
Yeah, so on the families, it becomes economically burdensome. Their wages haven't improved appreciably, and at the same time, their health insurance premiums are going up. The co-investments on the marketplace may have gone away, which means that they may have chosen to forego health insurance to put food on the table. Hard choices, and so that is a impact on families, our friends, family, neighbors in our community. So when people do present to us in primary care without insurance, we have people who help them try to find something in the marketplace, or do they qualify for Medicaid? It's not really clear how the work requirement's going to work out, or who's going to pay for the cost of doing that. That's not clearly stated or demonstrated. So we have a sliding fee scale discount. So if you're under 200% of federal poverty, at the lowest level, people pay $15 to see our providers. It's 15.45, 15.30, 45, and 60. That comes against a backdrop of we haven't seen an increase in federal investment in our work in a decade, which is a $750,000 economic erosion. So that's made things difficult for us. At the same time, maybe they don't come to us and things aren't taken care of preventively, and they show up at a hospital's emergency department uninsured. That becomes uncompensated care. And the critical access hospitals have tight margins when they do have a margin. So they are critical access for a reason. Someone decided that it's imperative that these are existing in this community or that community. So that's important. So I worry about their fiscal capacity against a backdrop of decreased investment into the residents of New Hampshire who are making hard choices, who may not be able to afford health insurance. We're still going to see people, as are the hospitals, and it puts financial burden on them. And as Jaime has stated, that lack of investment is more likely, as history has shown us, to continue to drive up health insurance premiums. And if it doesn't drive the premiums up, it drives up the out of pocket. So it might look good on the front end on the premium. You're on the hook for more dollars over the course of the year. Maybe your co-insurance is higher, your total out of pocket is higher. So I worry about that, because for every dollar we invest in primary care, we actually save $13 later. So we're a really good investment. when diabetes is properly managed, congestive heart failure is properly managed, these people will not need to go to the emergency department, will not need to be hospitalized. So that's, for me, it's just a good investment.
And I want to ask about staffing shortages. You mentioned it earlier, and it's chronic in the western part of the state and the northern lakes region into the North Country. And of course, when a healthcare facility faces staffing shortages, they have to pay more for temporary folks to come in and fill the gap, or the impact is the patients that they serve have to wait longer for medical care. How's that affecting the long-term stability of community hospitals and clinics across New Hampshire?
Well, I think you're right that when we look at the workforce development, we, as some of the hospitals, have had some successes working with local community colleges. White Mountain Community College has an RN program. They have a certified medical assistance program. And then the North Country Health Consortium uh, works to get kids engaged in healthcare careers in the high school years. Littleton High School has an allied health program. So at the hyper local level, there are some interesting activities going on collaboratively to address it. It is not a fast process. I have not had to use locums on the medical provider side, nor travelers on the nursing side. Uh, they are more expensive. They come and they go, so that from a relational perspective, it can be disruptive, no matter how technically competent they are. They're itinerant workers. They come into a community, they stay for a while, and then they go. And that's it. It's inconsistent with rural communities where we live, work, and play. We see each other at the grocery store. So we kind of take care of each other at a hyper local community level. So it is a challenge, and especially when you get into specialties. In some instances, there's some interesting tele-ICU work being done in the North Country at LRH, I think, as well as AVH with Dartmouth. So that's an important use of technology to bring care closer to the patient that's high quality in a community that they feel comfortable in. They're used to that hospital. They know how to find it. So there are some innovative, creative works going on in the North Country. It's still a challenge, and especially if you get into the nursing homes, assisted living,
Yes.
it's increasingly challenging. If we look at younger workforce who may have families, then we're into childcare challenges. And in a rural area where we often have too few people over too many miles, where do you put the childcare? What works in an urban area in more central with a dispersed population, it becomes increasingly challenging to be effective, efficient, and financially sustainable in a variety of areas. So those are some of the unique rural challenges that we're facing. In addition to the fact that we're in one of the oldest, fastest aging
Yes.
states and regions in the country. 40% of our patients are over the age of 65. So their complexity, they have more meds, they have chronic health conditions, they may have behavioral health conditions as well. So it's a more challenging area to work in rural, whether it's hospital, nursing home, home health, or primary care. It's a more challenging conversation. We get along pretty well, which is good. So at least the collaboration is there. We all show up.
Well, you raise an interesting point that rural New Hampshire faces some pretty tough hills to climb. You talked about the cost of fuel, the cost of heating homes, the scaling back of hospitals, the merging of hospitals and some clinics, housing costs, child care costs. So we've had some good news where we're set to receive some significant new funding, which is being called Go North. And that should have an impact. I guess my question is Go North enough to address the current financial pressures? And what happens when the Go North funds are spent and we're still facing the other inherent economic issues that impact rural New Hampshire?
I think those are great questions. And to start with, probably the most straightforward one, which is a straight up mathematical um, calculation. At face value, the $204 million coming into the state of New Hampshire is a significant investment. That is a fair statement. It's equally fair to look at the de-investment in the Medicaid and the ACA as being larger than that and will last longer. So they're two different conversations. That the long-term investment raises significant questions about sustainability. The short-term investment presents interesting opportunities to do innovative work that perhaps might not have been done
Mhm.
in other circumstances that I've been in my career under the Balanced Budget Act. There's market consolidation. In home health and hospice, there is market consolidation. So I would be surprised if there isn't some level of market consolidation. I don't know how it will be done. It may be done thoughtfully over 5 years. I would be upset if we get to the end of 5 years and we go, oh, we need to do market consolidation with no additional funds, and we got to do it in 2 months. There's that concern. When I look at the investments, I look at investments that are one time of what is the legacy of the investment and how long will it last? And so when I look at the investments, they're coming out in several instances that CDFA will be managing all things bricks and mortar. And the bricks and mortar, my understanding, is renovation, not new build. So that appears to be a framework to work within. For us, there are investments we can make in renovation that will last 25, 30, 40, 50 years. I won't have to take operations money every 5 years to do something like paint a building. I can reinvest it into cost of living and mission and patient care. The innovative work as it relates to patient care and process flow is going to be managed through the Foundation for Healthy Communities. And so those RFPs would come through that group. When we look at workforce development, there's at least two. UNH has a role to play, as does the community college system that I'd mentioned earlier. And then there's another group of money that haven't come out yet, and that's for the community mental health centers. I don't know if I've ever seen an investment made in them significantly since I was born in 63. And that is an area that really needs a lot of investment. As we've moved away from institutions, we did not fund properly community mental health centers. Why do I say that? Because if we'd funded it properly, we wouldn't have drug court and behavioral health court. When we get the care at the right time, the person earlier on, they won't self-medicate and things like that. So I'm pleased to see those sorts of investments. So those are the ones we look at of, is there technology to invest in that manage transactions so people can spend time with people? Healthcare is a relational conversation, especially in primary care. So it's going to open some interesting opportunities. An area that we've invested and will continue to invest is upstream where people live. We have a food as medicine program, 30 minutes prep to plate, under $5 a serving. We're sensitive about not using salt for hypertension, but it still tastes really good. And similarly, we're cognizant of carbohydrates for patients with diabetes. We have an early childhood development program. We've just integrated food as medicine, early childhood. We have teaching opportunities for kids 3 to 6 years of age. So by moving upstream and having people eat healthy foods that you don't have to understand what the chemicals are on the list, there aren't any. And 30 minutes is doable. Getting kids involved in the kitchen safely is doable. We're getting upstream to address things like obesity and congestive heart failure and diabetes before they become a thing. So that's the long game. And it's really a community engagement. So far, those sorts of activities people have enjoyed. And by bringing people together, it also addresses social isolation and loneliness, especially in an aging population. They get together to play mahjong. They get together to play cornhole. Now they're getting together to cook and share a meal together, which people are really enjoying. So that's upstream outside of our house. And we're collaborating with the hospitals on this. They're thrilled about it.
Well, thank you. I mean, that those types of simple investments show that clearly, they're treating humans like humans can stop problems before they become problems. And I want to thank you. I know we're lucky to be joined by, I think, five colleagues from the media on today's conversation. My colleague Rachel is here, who will help if you're from the media and you have a question. Rachel, there's a special like question chat for them to put those questions into. Obviously, questions not for me, but for Ed, regarding the crisis with rural healthcare and where we're going as a state. Um, and Ed, if you don't mind, I know you'd be happy to answer those.
Absolutely. Best of my ability.
Thank you both. Yes, as Jaime said, if any members of the media have a question for Ed, I invite you to put those in the Q&A box at the bottom of your screen. If when writing your question, if you could just restate your name and outlet, that would be great for us. Thank you. Now first, we have a question that was submitted ahead of time by someone who could not make it today. And that question is, how are rural clinic closures like this particularly harmful for Granite Staters with disabilities and complex health needs?
It makes it more challenging. Transportation is a challenge, and it is an area of focus of ours. And we have some work we're doing on transportation. It's currently under legal review, and we're hoping to launch a Get There Together program in May, in part to address that. Yet people who have challenges in ambulating will need sometimes special vehicles, which are not always easy to get access to, and they're not everywhere. Yeah, so it becomes a challenge for them. So it is unfortunate to do that. Once they get to one of our facilities, the accessibility, we've been very careful about making sure that that's possible. In addition to that, to some degree, we're able to bring some care, not all care, to the patient using telehealth services. The state of New Hampshire codified in law what they call payment parity for commercial and Medicaid. So you do the care, you document, you code it. Whether the patient comes to us, we actually do in certain instances go see the patient at their house. We can't do that for everybody, or it's not solvent. If we do it for nobody, it's not good care. So we leave it to the patient and provider. Like this conversation, there's a certain things we can do through telehealth. We can't do everything through telehealth. So really it's left to the patient and provider of what works, what is clinically relevant, what is copacetic between them. And as I say, for the love of God, can we at least not lose money? Because we need to be solvent to be there for people. And as the patient's health center, my board is 51% active patients. So these are the sorts of questions that we work with our patients on co-designing a solution, because they often know best how to make it work. And they're often the best people to educate us on what's the best way to provide care for you given some of the special circumstances you have. I learn a lot by listening to what they have to say.
Thank you very much. Now those are all the questions that we have for today. So I will turn it back to Jaime, but I do invite any members of the media, if you have a follow-up question for your reporting, to please reach out to Jaime following today's call. Thank you.
Thank you, Rachel. Thank you, Ed. This is such an important topic because when we think about New Hampshire, we think of, our mountains, our lakes, Mount Monadnock, Mount Washington, Lake Winnipesaukee, all the jobs that are there in terms of the ski industry and restaurants and hotels. It's a big part of who we are and who our identity is. But, without maternity services, without affordable, accessible health care, without rural clinics and, safe distances, it's tough for those areas to exist, especially so reliant on seasonal employees. Rural New Hampshire defines our state, and making an investment is important in it, but that investment has to be long-term and forward-seeing. So, Ed, thank you today for joining us in this conversation. I know we'll have more. We're coming up on a Medicaid Awareness Month, and so we're going to do some programming around that. I want to thank Ed. I want to thank my friends from the media for joining us today and keeping this conversation going, because I think solutions are found through dialogue. And on behalf of Protect Our Care in New Hampshire and everyone else who cares about our care in this state, Thank you all. We'll see you again soon.
Thank you.